My name is Ashish Jha. I'm a professor of health policy at the Harvard School of Public Health, and I'm a practicing internist, and I'm here this morning with Dr. Karen Joynt. Karen.
Hi, I'm Karen Joynt. I'm a practicing cardiologist at the VA and also an instructor in health policy at the Harvard School of Public Health.
So we are talking about the U.S. healthcare delivery system. And in 2013, what we know is that we are living through some pretty difficult times, tumultuous times, lots of changes. And so one of the themes that we're going to be talking about at the Q-Core meeting this year is the role of the specialist as the healthcare delivery system changes. And so we are speaking with one of the national experts on this topic, Karen. Karen, how do you see the role of the cardiologist changing over the next 5 years as our healthcare delivery system tries to get to value?
That's a great question. I think some of the big innovations we're seeing in delivery system change are really things like ACOs, bundled payments, and all of those things right now are very focused on a primary care physician, specifically ACOs, really sort of building a system around a patient. But I think what remains to be seen is how we integrate specialists into those discussions. A lot of the really big ticket items are controlled by cardiology, by orthopedics, by other specialists. And so fundamentally, I think we have to find a way to engage specialists in the discussions about how we're using technologies, how we're using value, and really integrate specialists into those conversations. I don't think that's happened just yet.
And what's the risk if we don't have cardiologists at the table for those discussions? I mean, can't the primary care physician ultimately make the decisions about what's good for the patient in consultation with the patient? Do we really need the cardiologist there?
I like to think that we do, or I might be out of a job. But no, I do think there's a role for having a primary care physician to coordinate all different aspects of care, but sometimes a decision about, for example, using a defibrillator, or whether or not we're going to proceed with a stenting procedure, or a percutaneous valve. Some of those decisions have gotten so specialized and so sub-specialized that without really bringing the specialist to the table, I don't think we'd actually allow a patient to really make the right decision for them. Right now we don't have a system that's particularly built around being able to do that with specialists and with primary care physicians together, but I think we have to get there if we're going to really build value.
And what's your sense of what life for the cardiologist will look like in this new world? So let's say they're part of that discussion, they're around the table. How has their life changed from what cardiology practice used to look like 10 or 15 years ago?
I'm guessing, since I wasn't a cardiologist 10 or 15 years ago, but my feeling is that we're going to be moving more from sort of cardiologists as rogue practitioners on their own and more into actually all physicians sort of being under these umbrellas. And if you're going to be practicing under an umbrella, that may come with some benefits. There's certainly benefits to being part of a system, but I think we're seeing a lot of sort of consolidation among private practice, among academic practice. And there's going to be, I think, some growing pains in figuring out how everyone's going to have to work together. You're giving up some autonomy when you join these types of systems, and that's going to have to be balanced with the benefits of being part of these discussions.
And do you see downsides for patients with that loss of autonomy?
Potentially. I think patients worry a lot about, things like the death panels, that someone's going to be making decisions that don't apply to each patient about what the high value thing is, what a patient can get. And I think there may be some tensions there in thinking through who's going to be sort of holding the final say on what we will or will not pay for example.
That's helpful. So you're a researcher, and we're at a research meeting. What's the research agenda around this? What do we not know today that we really need to learn over the next 5-7 years to do it well?
I think we're starting to understand more about value, and certainly we need to understand better how to study value. Part of the difficulty is in recognizing that the value of an individual procedure may be vastly different depending on who you're applying it to. So if we have very expensive procedures, for example, the percutaneous valves, very expensive, but really life-altering. And if you pick the right people and you can restore functional status and you can give people years of sort of productive life, that's probably a very high-value proposition. As we move from clinical trial controlled application of very high priced technologies and put it on the market, FDA approves it, all of a sudden anyone can get this procedure done, I think we open up a very different range of value. And understanding how to study value in the real world and not just in a controlled clinical trial, I think we'll have to figure out as a research community.
So I like that, and the notion of value certainly seems to incorporate individual patients' own values, right? That if I value certain things more than others, I may make different choices as a patient. Which gets us to the other sort of buzzword of 2013, which is around patient-centeredness. I thought we always had a patient-centered healthcare system. That was the whole point of medicine. But people seem to be very focused on that. What do you think the role of patient-centered care is? How do you interpret that? And then how do we get to a system that really does incorporate individuals' values and preferences into these complex decisions about what kind of services you get, how to pay for it, et cetera?
Sure. I think there's probably two pieces to sort of patient-centered care and patient engagement. One is really on engaging patients in managing their disease and understanding their disease across the spectrum of that disease. So that for heart failure, for example, when we see patients really cycling in and out of the hospital, that we do a better job being creative about engaging them in the chronic management of their own care. I think a separate issue is helping people make the right decisions. And we talk a lot about what a patient values and how they might then choose an intervention or not, or how they might move toward different models of end-of-life care. And I think what is difficult to understand is how much that can be shaped by how physicians interact with that patient. So how much are we coming to patients and saying, these are our values as a healthcare system? How much are we sort of really hearing their values? And how do we do that in a way that's both rigorous and sort of observable, as opposed to just saying everyone should talk more to their patients? I think there's been some really neat programs developed by people within QCore, for example, to start to present a patient with an individualized risk-benefit profile and help them understand that having a certain procedure does not mean life or death for them. It means a difference in life or death for a large group of people, but what does that mean to a person? I don't think we've done a terrific job educating providers or patients about sort of how to use the research that we do, and I think that's another piece of it, decision-making and then engagement in chronic care.
And why do you think it's been so hard to get patients engaged in chronic care? I mean, people want to be healthy, they want to stay out of the hospital. Why is it so hard?
I think it's the same way that it's hard to engage in your own sort of care. We all know we should be eating better, we should be exercising more, and it fundamentally takes a lifestyle change. And I think we don't understand enough at what the barriers are that really people face. We send people home on 20 different medications and expect that they can manage to take those multiple times per day. Why, when we fill prescriptions, does everyone get 20 orange bottles? Why do we not have a system in which they come in a blister pack where you know what you should take in certain times of day? Why haven't we figured out better ways to bring the care to people instead of making them come to care if they live in a rural area, remote area? There's so many different ways that we haven't really moved the system towards people.
Yeah.
And I think that's why it's hard. It's not hard. People know they want to do better, but that's not the piece. It's actually finding tools that will let them exercise those desires in a way that's productive, as opposed to just, I want to do better.
Sounds great. Well, Karen, thank you very much for taking the time to chat. It's my pleasure. And this has been a discussion with Dr. Karen Joynt, cardiologist extraordinaire at the Harvard School of Public Health and Brigham and Women's Hospital.
Thank you.